So let's just get the elephant in the room out of the way first, okay? And that is, why the heck would anybody decide to do that? Specialize in diseases of the colon, rectum, and anus. So first of all, it allows me to put poop emojis on all of my presentations. But more importantly, really, I think that colorectal surgery gives you the opportunity to make deep decisions from complex data along with patients. So you're talking to someone, educating them about their disease process and helping them through sometimes a pretty protracted process. And at the end of that process, they know more and have been potentially helped by your care as well. And so it is probably one of the best subspecialties in general surgery because of that. So today during this lecture, I always like to start with goals and objectives because I am an educator. So by the end of this presentation, you will know how to defecate, which you probably already know how to do it, but you'll understand how it works, and it's actually a really fascinating process. And you'll know how to do it with and without a rectum and anus. On a broader level, we're going to talk a little bit about making good decisions. And I'm going to give you examples of making good decisions with your patients in the clinic. And then about making decisions at life junctures and pretty much everything. So, pretty important. And the last thing is we're going to just throw a little bit of education in there on how to be a strong lifelong learner. Because I think that if you can teach other people in your life, so in my case, patients, how to do that, and if you can learn how to do that for yourself, your life will be that much richer for it. Right, so these are our objectives. Just in case you were wondering whether I have the qualifications to give this talk, I want to point out that I am an assistant professor in this stuff, okay? And there are so many proctology cartoons out there on the internet, it's really hard to choose just one. All right, so first we're going to start with a little survey. So I want you to remember the scale from 1 to 6, okay? And I was going to pass out pieces of paper, but I think you guys are smart enough to remember numbers in your head, I think. So on this one side, you're going to be strongly agree, all the way up to 6 strongly disagree, okay? And you're going to pick your answer to each of these questions and then add the numbers up, okay? All right, so here we go. So number 1, do you agree that you have a certain amount of intelligence and that's innate? Strongly agree, mostly disagree, disagree, or strongly disagree. All right, so think about that question and pick your number. All right. There's going to be 4 questions, so you're going to have to add 4 numbers, okay? Ready? Okay. Number 2. You can learn new things, but you can't really change your basic level of intelligence. All right, do you agree? Do you disagree with this statement? All right, so far you've got 2 numbers, add them together. 3. You have a certain amount of talent, and that's innate. And 4, you can learn new things, but you can't really change your basic level of talent. So you can see these are kind of repetitive, but one's a little bit more about intelligence and the other is about talent. All right, so everybody have the 4 numbers added together? All right, so anybody who is got 12 or less, I want you to raise your hand. Okay. All right, anybody who got 13 or more, I want you to raise your hand. Okay, all right. So we're going to move on, and remember that for now. The next thing is we're going to start with a couple of clinical scenarios, okay? So I'm going to ask you to imagine and put yourselves in the shoes of some potential patients. So you're going to be one of them. So the first is you are the patient, okay? So you are yourself, okay? And you have had ulcerative colitis for 4 years, okay? So ulcerative colitis is a disease where your colon is unable to function anymore, and basically what it has resulted in for you is that you're stuck tethered to the bathroom every day. So you're going to the bathroom to have bloody diarrhea 15 times a day. Okay, so you'd never be able to go on this OCE later today because you can't be that far from a bathroom. In the last year, you've lost 20 pounds because you're basically unable to keep your nutrition in, and you're always tired. Like, you're so fatigued because you don't really have any blood. You know, your body's kind of working to keep up with the blood loss from it. And you've been seeing your doctor for the last few years, but you're really no longer responding to medications at this point. So they've tried all of the different medications that we can basically give for this disease, and there really isn't another option anymore at this point. Okay, so your options at this point are surgery, and there are 2 types of surgery that you could have. The first is one that removes your whole colon and rectum and gives you what we call a permanent end ileostomy, okay, which is where we take the small bowel and bring it up to the surface of the skin, and then you poop into a bag, okay? Sounds pretty scary. And the second option is a reconstruction. So we take the colon and the rectum out, but instead of bringing the small bowel out to the surface of the skin, we're going to make a little pouch out of it and connect it down to the anus. So you still go from the bottom, but you know, imagine you don't have your colon anymore, so the bowel movements are still, they're going to be a little more loose, right? So I want you guys to raise your hands. Anybody think they might choose the first option? Anybody? We got a couple of hands for the permanent ileostomy. Okay, yep, okay. How about the second option? All right. Anybody undecided? We got a few undecided hands too. Okay, so keep this in mind. We're going to come back to this too, okay? So scenario number 2, okay, the patient is your mother. All right, and if it makes you really sad to think about your mom being sick, pick somebody else, okay? But I want this to be personal for you, okay? So think of somebody personal affected by this, okay? So your mother just got diagnosed with rectal cancer last week. Not the sexy kind of cancer, but really the unsexy kind of cancer where it's in the rectum. And we're told that the tumor is pretty bulky, which means it's a big tumor that was growing inside the rectum. And we're also told that it's right above where the anal sphincter complex is. So it's what we call a very low tumor, okay? And she also obviously wants to be cured of the cancer, right? She's got a lot to live for. So we have a couple of surgical options for her also, okay? So the first option is what we call a proctectomy with a permanent end colostomy. That means we go in and we remove this rectum with its tumor and the cancer to get rid of the cancer. And then instead of making any connections, we bring the colon up to the surface of the skin as a colostomy. So again, the poop goes into a bag, right? And the second option is an ultra-low coloanal anastomosis. So we bring some colon down and hook it up to the bottom, so she still goes from the bottom, okay? I got some kind of grossed out faces here. So, so take a minute to think. Does anybody think about your own mother? Anybody think that she might choose a permanent colostomy? Okay, we got one lonely hand. And anybody think that she might choose to have a low connection? Lots of hands. Okay. All right. So keep that in mind again too. Okay, we're gonna talk about it. All right. I forgot to mention in the beginning that there are some slides in this lecture that have guts. Are you ready for some guts? Okay. So both of these choices involve an ostomy, right? So that's the scary, scary part about this decision. And this is kind of what an ostomy looks like and some of the supplies that people use to bag an ostomy. So as you learn a little bit more about it. This picture is actually a famous patient on the internet. So some people have no choice but to have ostomies, but choose to live with it with a sense of joy and kind of educate other people about it. And so they're out there actually giving lectures on YouTube. But generally, most people, when they think about it, are like freaked out and think that it's a terrifying idea. And so this is kind of the crux of the problem that we sometimes have to deal with. So we're going to kind of go through and talk all about the colon and the rectum and give you a little bit of basic understanding about this, and then we're going to revisit all these questions, okay? So your colon is actually a pretty boring organ. I'm going to tell you that straight up off the bat. Like if you were looking for a dance partner, colon is probably not going to be your favorite. The colon has two jobs. They are to absorb water, right? So by the time that your food has reached the colon, your stomach has mushed it up, your small intestines have digested and broken down all the proteins and the carbohydrates and absorbed everything that you're going to use nutritionally. And it's gotten all the way down to the colon, and everything is taken out of it except for the waste, right? So the colon's job is really just to reabsorb the water out of the poop so that it becomes more solid, and then slowly move the poop along in a very orderly fashion from beginning to end as the water gets absorbed, right? So kind of a boring guy. And it doesn't really know, how to do really anything but that. It doesn't really learn anything but just, this slow squeeze forward, all right? When we look a little bit deeper at kind of the levels of its wall, you can see that it has muscular layers. It has actually its own nervous system that helps kind of make that happen. And it has glands that help kind of secrete mucus to slide things along and to absorb water. And if you look at it even at a deeper level, at a microscopic level, you'll see these nice orderly crypts. You've got some areas where the mucus is getting secreted, which are these kind of what we call vacuolar cells in the middle. And then layers of muscle that are strong enough to kind of squeeze things forward. So then we get to the interesting guy at this party, which is the rectum, okay? So the rectum is actually a special organ, so it is much smarter than the colon, and it is what gives you the ability to hold your poop in, right? So taking a look at kind of the basic anatomy of the rectum, you've got an area where you can store the feces on the way out, and you've got sphincters of the anus that are right below it. And importantly, you've got an internal anal sphincter here and an external anal sphincter here. The internal anal sphincter is not under your control, so it's controlled by the autonomic nervous system. So it actually spends most of its time in a contracted state, obviously, that otherwise you'd be letting poop out or gas. And the external anal sphincter is what is under your control, okay? And then surrounding those, you've got your pelvic floor and some muscles called the levator ani, which literally means like the lifter of the anus in Latin. Very cool. And as you're sitting there, I want you all to kind of make a motion on your seat of, okay, I'm holding the poop in. Just kind of try that for a second. Right? So you can feel that. It's something that you can control. You can kind of lift your pelvic floor, all right? And it's actually really important, all right? So, okay, sorry. I forgot to mention also that this is a neuroscience lecture. So if you look at normal rectal physiology, right? So the two special things about the rectum are capacitance. Does anybody actually know what can you tell me what capacitance is in physics? Okay, and then? Okay, and then you discharge it, right? So capacitance is the ability to hold on to something and then discharge it later, all in one go. So your rectum actually has this special property called capacitance. It can expand to put the stool inside until you're ready to go. So, right now might not be a good time because you're sitting in the middle of the row in lecture, but in about an hour, then when it's time to go, you can kind of signal to the rectum and it's going to be able to give you that nice squeeze to make the bowel movement for the morning, right? So that's a really special property of the rectum. This is the guy you want to dance with at the party, not the colon. So another one is continence, right? So we have the ability to hold in the feces until it's time for us to go, right? And it depends on a tightly regulated myenteric plexus, meaning there's a nervous system that is tightly connected between the rectum and the colon and your brain and the anus. And this is the result of a couple of things called anal sampling and the rectoanal inhibitory reflex. So this is a picture of some of the neural connections that are necessary in the walls of the rectum with the various neurotransmitters that both your autonomic and your conscious nervous system are using to communicate all this information. And what happens is you have an anal sampling reflex. So as the stool descends in the rectum, right, the colon is just always pushing it down, and eventually it gets there. At some point, the rectum distends with enough stool because of its capacitance that stretch receptors inside your rectum get activated. And what happens is they send signals via your parasympathetic nervous system and to your brain so that you are conscious of it, to tell your brain and the parasympathetic system that, hey, there's stool descending the rectum. And the internal anal sphincter actually is triggered by that parasympathetic reflex to just lightly relax a little. And what that does is it brings whatever it is that's in there down to the top of the anal sphincter complex, where there are a number of really sensitive receptors to tell exactly what that is. And that is actually how your anus is able to tell the difference between solid, liquid, and gas states of matter. So it's actually kind of a wondrous thing that when you have gas inside the rectum, you know that that's going to be gas, right? Because, you might be in the middle of lecture and not really want to let it out right now. Or you might be next to your brother and be like, let's let it rip, right? So it's important for you to know exactly what's going on. So that's the anal sampling reflex. There's also an inhibitory reflex that allows you to actually defecate. So the rectum distends with stool and sends that signal up the parasympathetic nervous system and to your brain. And when your brain is alerted to the fact that, yes, I am on a toilet, and yes, my pants are down, the brain, you're able to send the signal back to the rectum, again via a parasympathetic pathway that contracts the rectum at the same time as it inhibits the anal sphincter complex. And by inhibit, I mean it's normally contracted, right? So when you inhibit it, it loosens up and opens, and that's what allows you to let the bowel movement out. So imagine, though, that we took all of this away from you. Anybody want to guess what might happen? Yeah.
As soon as it's there, it just floats.
Right. So if we took this organ away that has these connections in it, and they're all tightly regulated, and we replaced it with something else, like a J pouch that we were talking about, or even the colon, right, then we may not be able to sense all of these things as tightly as we used to. And that's actually really important for function after surgery. So we're going to move on to ulcerative colitis. So think about this first patient again. Okay, so ulcerative colitis is actually a really interesting disease process. It's one of the inflammatory bowel diseases, along with Crohn's disease. And we are actually not completely sure what causes it. So what we do know is that there's an intense autoimmune response to your own gut in this disease, and in ulcerative colitis, specifically to the colon and to the rectum. but we don't know what causes it. When ulcerative colitis and its brother disease, Crohn's disease, were first discovered, we thought it was a genetic disease because it tended to run in families, and it was kind of first mainly described in families of Ashkenazi Jews. We then realized that, well, I mean, there's another thing about families, right? That they live together, and they tend to cluster in the same environment, eat the same foods, experience the same outside environment. And so we wondered if maybe there's something else going on. We don't know. All we know is that there's an autoimmune response, and actually all of the medications that are available for targeting ulcerative colitis these days are targeted towards your body's immune response to whatever it is that's actually causing it. And on the right, you can see a whole litany of genes that we figured out that might be associated with ulcerative colitis and Crohn's disease. But there's no clear one pinpointed cause, and maybe in the end there won't necessarily be. I do theorize that probably sometime in like the next 10 years or something, someone is going to figure out that there's some small molecule or maybe even like a prion or some yet undiscovered microbe that people get exposed to that is the trigger for this disease. But we're going to leave that to the biologists. So symptoms because of this include just having really crampy abdominal pain, weight loss, and eventually, when it gets bad enough, bloody diarrhea. And sadly, all of the medications that we have to treat these diseases are medications that actually play with your body's immune response to the disease. So we have big guns that just knock out your entire immune system because you're dealing with this disease, like steroids. We have inhibitors for different pathways within the proper immune system, so TNF, for example. And all the time we're coming out with more and more targeted small molecule drugs for these diseases, but still haven't really figured out kind of the root cause. This is kind of a nice picture at the microscopic level of what happens in ulcerative colitis. So you remember our normal looking colon from earlier with its nice orderly crypts here. And the second picture over here is from the colon of someone who has ulcerative colitis, and you can see what we call a lymphocytic infiltrate. So this is actually the lymphocytes from your immune system actually kind of infiltrating the tissues and messing them up, so you see this distorted architecture of the crypts in someone who has severe ulcerative colitis. So we have some colonoscopic images also. So this is normal colon on the inside, on the left. And for someone who has ulcerative colitis, you can see how miserable that might feel, right? So the rationale and options for surgery in ulcerative colitis. Well, fortunately, if you have ulcerative colitis, we can actually cure you, which we can't say for that many diseases. So historically, we have found that people who develop ulcerative colitis, if we remove your whole colon and your rectum, then you will be cured of the disease for life. And I also have to mention that if you're left with ulcerative colitis for many years, so we know that it takes about 10 years to 20 years, you will eventually develop dysplasia and then cancer, because all that inflammation is constantly driving cell turnover in your colon. And so surgery to remove all of the disease also mitigates that chance of cancer for patients who have it. Okay? We don't need to do it all right now, but all of the diseased colon and rectum has to be removed eventually. And we have the two options of leaving you with an endoleostomy or a restorative procedure, which is the J pouch. So we're going to step through those. So for the surgical technique, to leave you with an endoleostomy, basically we go through and remove the entire colon and the rectum, and the ileostomy is brought out to the surface. This can be done in one procedure, or it can be done in two, depending on how sick people are. So Does anyone imagine kind of why we might choose to take this in 2 steps instead of 1? Yeah.
So there's not too much shock for the body at one time.
Exactly. So some patients with this disease are understandably so sick by the time that they get to needing surgery that it's a huge shock to the system to have a huge surgery like removing your colon and your rectum. And removing the colon is actually a relatively easy surgery. I'm telling you, colon is like an easy gun, okay? But removing the rectum is actually a very dangerous surgery that has a lot of potential complications. And so for these patients who are super sick, instead of telling them to go and run a marathon right away, we get them to weigh station at mile marker 1 by removing the colon and giving them a temporary ileostomy or whatever ileostomy that they might keep. Leave the rectum in place and then let them rest at mile marker 1 for a few months until they recover all of their nutritional stores, build up their blood supply again, and feel healthy again in order to finish the surgery. So that brings us to the second possibility, which is a restorative proctocolectomy, which is a fancy name for taking it all out and putting something else in its place, right? So again, we can do it in 2 stages or 3, and we remove all of the colon. If you're really sick, we'll leave the rectum behind and come back for it at another time, okay? And then in another surgery, we're gonna take out the rectum, we're gonna make that little J pouch out of the small bowel and hook it up down to the bottom. And then, but at that time, we should probably protect it. So you'll see in a second that a J pouch actually has a lot of little stitches in it to kind of keep things together. And we don't want those to come apart because your nutritional status is bad or it's under tension, right? And so, so we want to protect it. And what we do is we bring up a diverting ileostomy. So the patient actually does still have a bag that's temporary that bypasses it. So the food goes down through the stomach, it gets digested, and comes out through the ileostomy. So it doesn't go all the way down to where the pouch is. And we give that pouch a few months to heal until it's all nice and solid. And then we come back and we reverse the loop ileostomy, and then now they're fully functional and going from the bottom again. And this is actually, so this is actually illustrates a little bit why it is important to stage these procedures sometimes, right? So if you had, this is actually probably one of the top 10% of most diseased colons that I've ever resected for ulcerative colitis. You can see, I'm just going to tell you because you probably haven't seen a normal colon before, but a colon should not be like this. So a colon in a normal person is about 4 centimeters in diameter and soft and not expanded like this. And so this is an example of someone who was incredibly sick, who had an incredibly diseased colon that we had to take out and allow them to rest at that mile marker first. All right, obligatory growth slide over. All right, back to the J pouch. So we choose a good spot in the small bowel. And what we do is we flip it on itself, and then there's a whole row of stitches and staples that goes down the middle. So we take something that is double barrel, and we open it up and connect it in a way so that it becomes single barrel, right? So can anybody guess what kind of natural function of the rectum it is that we're trying to reproduce by doing this? Yeah.
Storage.
Yeah, exactly. So the capacitance, right? That thing that was lost because you don't have a rectum anymore. So we're kind of like, okay, well, let's rack our brains for some ingenuity. Like, how could we give this person a little bit of that back, right? And actually, surgeons throughout the last several decades have messed with all sorts of different configurations for this pouch. So people did a J pouch, there was an S pouch, there was a W pouch at some point, because we said, well, you know, I mean, if more is better, then how about more, right? And it turned out that after a lot of experimenting, that the J pouch kind of ended up being the best. It does stretch to some degree, but it doesn't have so many of these little areas where something could leak or go wrong compared to the other configurations, right? And then what we do is we bring it down to the anus. So you recall our little diagram earlier with your internal and external sphincters. We leave those so you still have control, right? And internal sphincter is no longer really connected to that nice brain autonomic nervous system, but we leave it there so you still have some sphincter muscle there. And then we connect it in a circular way, right? Does anybody kind of have a guess as to what J pouch function might be like 3 months down the line because of this? Nobody's sure. So, do you think that you might regrow those nervous pathways? Maybe, maybe not. So some people, so in fact, actually, after about a year, so it takes a whole year for some of those nerve pathways to regrow. It'll never be the same, but it's actually, you can demonstrate a reaction similar to the sampling and rectorenal inhibitory reflex in patients who have a pouch in place about 1 year after surgery. It's never going to be at 100%, but it's usually somewhere around 50%. Here's some illustration of how the pouch is actually getting made. So we actually have a fancy stapler that we put into the bowel to fire 2 lines of staples and divide down the middle. And we do that all the way down to the tip of the pouch until we're all the way through, and then the pouch gets connected downstream. Okay, so what things might we need to talk to patients about prior to surgery? Well, typically I'm going to go overview the expectations with the patients right before, right? So with an ileostomy, yeah, you have a pouch that the poop is coming into, but it's actually fully sealed, it doesn't smell, it doesn't leak, right? And you have to empty it 3 to 4 times a day, but it can stay there and it's not going to come out until you're ready to go change the bag, right? The bag itself has to be changed somewhere between every 3 to 5 days. If you have a J pouch, okay, typically you have at least 6 bowel movements per day. So if you think about it, the best J pouch has about 6 bowel movements a day. The average is more around 10, right? The bowel movements are still a little kind of squishy, even though they're not totally watery or bloody. And then actually usually people have at least 1 during the night or around bedtime. And then especially in the beginning, and for some people there's a persistent amount of this, urgency and leakage, okay? So you might be like leaking at the bottom, unable to control it. So that's something to think about, right? Especially if you just came from a situation where that was the problem that you started out with in the first place. So imagine kind of like what your lifestyle is. Like, are you able to get to the bathroom that many times a day? All right? So then I have to sit down and talk to the patient. Well, what are your priorities and goals, right? And how fit are you? So usually folks who are younger are fit enough to have a surgery like this, which is pretty big to recover from. But folks who are older may not have the physical reserve that's necessary to recover. So that has both a psychosocial and a physical component. And if people choose to have a pouch, they have hopefully an opportunity to get working on being optimized for that beforehand. So they really buff up their nutrition. You guys ever had an Ensure drink? Yeah, okay. They're really good. Chocolate on ice, okay? And another actually component to making a J pouch is that in very, very obese people, it's actually even difficult to get that bowel down into the pelvis to even make the connection. And so sometimes people who really, really, really want that pouch connection, we tell them, go lose some weight. Go get on a weight loss program. And once you've lost 20 or 30 pounds, if you come back, then you'd be a better candidate and this surgery is going to be more successful for you. And think about, again, what kind of lifestyle you're going to lead as the patient. Are you active? Are you more kind of sedentary? And how is your body image and how is that developing? And a lot of people, young people especially, who come in with ulcerative colitis and want a pouch, this is a very important component of life planning that you may have never thought about before, but you're now being forced to confront it by your disease. And what tools are in your coping, right? What family are around to help? What kind of support system does your patient have? And then we start to align things together. And all of this might be timed around important events in someone's life, and it may actually be dependent on someone's degree of risk aversion. So if you're the type of person who says, oh, I don't even want to have the chance of having a complication, then you may side one way or the other based on that. And then finally, young women might eventually want to become pregnant, right? And so doing all of this work down in the pelvis sometimes actually affects that. And so it's actually an important thing for people to understand when they have this disease and we're talking about it. So just to kind of run through the litany of things that could go wrong with the J pouch, just to kind of scare people a little bit, right? So the pouch could actually fail. A significant percentage of people develop something called pouchitis, which means that the small bowel is not designed to hold on to stool as a reservoir, right? Its job is really to absorb nutrients and pass it down the pipe. And so when you ask it to become a reservoir, it might become irritated, and people end up with similar symptoms to when they had the ulcerative colitis in the first place. It could get infected or leak, it can get obstructed, it can develop a fistula if it leaks, and all sorts of things, stricture, dysplasia, which is actually a progression towards cancer in the pouch itself. And then some people actually have sexual dysfunction, so that's kind of an important thing to know as well. We have some kind of just illustration of how bad it can be. So if you have a connection that breaks apart, it can get very irritated, and we end up having to go back in and take the pouch out again. These are some pictures of a pouch fistula. So this is a picture with the patient sideways, okay? And right here is a leak from the pouch anastomosis, where it's connected down to the anus. And you can see that there's a thin line of a fistula that's coming up behind the pouch. So that can't be good for you. It's infection. Pouchitis is another thing. So we talked about it can just get irritated. So this is some of the pictures of what the pouch looks like on the inside. And you can tell it's not very happy. So it should be kind of healthy and pink and glistening like that picture of the colon that we saw. And instead it's ulcerated, kind of just like the ulcerative colitis to begin with, right? And again, more serious pouchitis can be really, really bad. And you can lose a lot of blood from it. And what we've done is studies to examine how we teach patients about the actual risks about this. So these pictures actually represent the percentage of patients who have each of these complications, right? So pouch failure, 6% of people, the pouch completely fails and doesn't work, and we have to go back and take it out. And it's represented with the graphic here. Actually, so look at this number. Up to 30% of patients have pouchitis at some point after having a pouch, right? So it depends on how we feel about that, right? Are you risk averse? Like, yeah, 30% is like, or, you know, like, that seems like a lot of people. I mean, or maybe you're like, well, I'm lucky, I'm gonna be in the 60%, you know, 70% of people who don't have it, we're gonna be fine. Depends on how you feel about it and the complications. 23% of people end up with a bowel obstruction of some sort, 9% with a fistula, and 13% with a stricture, which is an area where it's so narrow that you can't get it, the stool to go through, right? And it's important to like illustrate, well, what does this mean, right? So is it a big problem if I have this problem, or is it just kind of not a big deal? Does it last a long time? And you can see that pouch failure can happen early or late, and it's a pretty major problem if it does. Pouchitis is something that can last for a long time, but sometimes it's just a minor irritation. And so these are important things to kind of go over and think about together. Fistulas, for example, are a major problem. They might require surgery to fix, or they might require the pouch to come out again. So we're gonna switch gears, all right? Oh, I have a question. What is a fistula? So a fistula is where there's a leakage from one of the connections in the pouch. And so bowel fluid is coming out of the bowel into the pelvis where it doesn't belong. And instead of, because it has nowhere to go, it sits there and it can actually create an abscess, which is an infection, and then we have to treat it with antibiotics or drain it. And if it gets really bad, we might have to actually just remove the whole thing because it has gotten so infected and inflamed that it's not going to heal. All right. Okay, so we're going to switch gears. Now think about your second patient with rectal cancer. So rectal cancer, we don't have to kind of belabor the point, right? So it arises from the cells along the inner lining of the rectum. And if you think about mucosa, what it is the same stuff that's on the inside of your cheek, right? So there's where your mouth is, there's a juncture between the outside of you and the inside of you, right? So you have skin on the outside, mucosa on the inside. At your mouth, they kind of meet, right? And the same thing happens again at the anus. It's very exciting. So just think about those two things together, right? And so cancer typically, as you know already, we don't need to again belabor this point, kind of enlarges locally. And once it develops enough mutations in the pathways that control cell differentiation and apoptosis, etc., begins to spread, right? And it develops the ability to potentially spread along the lymphatic channels or along the blood vessels, and then eventually, by doing that, gets to other places in your body, right? And so, when you think about cancer treatment, you think about the potential treatments based on the different stages of where the cancer has gotten to. And again, symptoms might actually be nothing. So typically, actually, the most common symptom is somebody coming in with no symptoms at all, and something that was discovered incidentally. But it can be up to abdominal pain, and if it gets big enough, obstruction, so to the point where you can't go to the bathroom. So let's go back to our microscopic view, right? So on the left you have your typical normal colon or rectal epithelium with this nice normal architecture. And on the right is a picture of a pathology slide from a rectal cancer, where you can see tumor cells that have disorganized nuclei that are kind of invading the surrounding tissue. And again, this is all totally disrupted, right? And these are some pictures, again, to compare normal on the inside from a picture of a rectal tumor on the inside. So you can see it starts to kind of grow. It can eventually obstruct the entire lumen or the inside of the bowel, and eventually kind of starts growing outwards as well. So what are our treatment options? So going back to the different stages of spread, right? So if you think about it from a very basic and mechanical standpoint, surgery is something that can treat primary disease, right? So we can literally go in there and cut the thing out and remove the tumor. But what if little seeds of tumor have spread beyond what we can see as a surgeon, right? So then comes in radiation treatment, which is treatment for local disease. So another thing that's very special about the rectum is that because of its location in your pelvis, we can actually target beams of radiation at it from the outside. Anybody have a guess as to why we can do that for the rectum and say not for the colon?
Yeah.
Exactly. So it would be terrible, right, if we aimed beams of radiation from the outside of the body at an organ and then it kind of moved and then we accidentally hit something else, and that would probably be pretty bad, right? So the rectum is special because of its location in the pelvis. It's actually very fixed, which is another benefit of being surrounded by bone. So it's not going to move anywhere as we shoot the beams of radiation at it. And then finally, if the cancer cells have gotten truly out of the bag and spread throughout the body, then chemotherapy, and kind of the most traditional ones that we have for systemic treatment, are basically the full-on blitz, right? which is targeting any cell in your body that is dividing more rapidly than the normal, or dividing at all. And which is why you'll see that patients who are on chemotherapy have all sorts of different side effects from it. And someday, hopefully, one of our wonderful basic science or molecular science folks who've been lecturing here are going to come up with targeted treatments for something like rectal cancer and all the other cancers. But for now, this is the toolbox that we have. So over here you have a simulation image from a radiation oncologist who I work closely with of a rectal cancer radiation protocol. So you can see that they're trying to really irradiate well where the tumor is and then provide a field of radiation to the surrounding tissue where the tumor might have spread locally and any lymph nodes that are also in that area, while kind of very carefully avoiding the bone and other structures. Question?
So have there been any tests for treating rectal cancer with immunotherapy?
Not yet. Yep. Oh, sorry. If there have been any tests for treating rectal cancer with immunotherapy? Another question?
Generally speaking, does rectal cancer metastasize, or is it like more like a benign?
So rectal cancer does metastasize, and it actually metastasizes fairly easily because it has a rich lymphatic supply and blood supply. And actually, the two typical places are the liver and the lungs, and so that's part of our staging protocol for it. So the history of radiation treatment for rectal cancer is actually a really interesting illustration of how it is that we kind of use evidence and gradually change practice. So back in 1917, when surgery for rectal cancer was really, really prohibited because we still didn't have modern anesthesia techniques and we still didn't have modern blood control techniques that we have today, radiation was actually considered the gold standard. And what the first people did was they inserted radioactive seeds into rectal tumors and showed that there was a significant increase in survival at 5 years for those patients. They had all sorts of other issues because the radiation seeds stayed there and provided radiation to the pelvis kind of indefinitely. But their survival rate improved from almost nothing to about 25%, which is, back in that day, pretty good for a rectal cancer that was discovered. Once surgery got better, surgery actually became the gold standard. And it's interesting that finally in the 1990s, as surgery and radiation kind of came together to kind of collect data about how patients survived from surgery followed by radiation versus radiation followed by surgery, we found that patients actually had much better outcomes when they had radiation before surgery. And that's for a number of different reasons. Once you operate on this area and then irradiate it, you're actually kind of giving that area a double whammy in terms of being able to recover from both insults. And whereas when you irradiate things, it actually sometimes downsizes the tumor so that the surgery can be more effective. And so this is kind of part of this gradual learning process in medicine that is actually probably one of the more fascinating things about it. So when we go back to surgery, first of all, we talk to the patient about what they're going to have, radiation or surgery first, and it depends on the stage. And they can have either two options. So the first is just a proctectomy, which is resection of the rectum where the tumor is. And what we talked about on that first slide, right, which was an end permanent colostomy, right? So then you're pooping into a bag. The second option is a very, very low, what we call anastomosis, is our fancy word for a connection, all right? And so this is a picture of actually how we do it. So we get a fancy stapler that comes up through the anus, and we bring the two ends of the bowel together, and the stapler actually fires a circular ring of staples so that the two ends can be connected all the way around. And you can imagine that we're actually now bringing that colon all the way down to the anus, right? So before I go on to the next kind of discussion of expectations after surgery, does anybody have a guess as to like, what might happen if we bring that colon down all the way to the anus?
It was sort of in the water.
Okay, so maybe not more watery, because you still have the colon, right, to kind of collect all the water.
Do I get narrower everywhere because it's pushed out?
Not necessarily narrow. The stool is still going to be the same stool that is coming downwards. How about your control of the stool, though?
No
Okay.
control.
Okay, so you're guessing maybe no control. How about like maybe less control?
Very
Still limited control. Okay. And then there's another one that's very, very distinctive about this. So think about it. Your colon's like. There's nowhere to store it, right? So it just keeps coming. And so when we talk about expectations after surgery, patients who have a low colon anastomosis have something called clustering. So when it's time to go to the bathroom in the morning, they're going to be on the toilet, and then a little bit of the poop comes out, and they're like, oh, okay, okay, now I'm good. All right, oh, okay. 5 minutes later, it's time to come back again, because we didn't have that capacitance to store it and then release it all at the same time. So that's something called clustering and urgency, and you typically get that 3 to 4 times in the morning, where you have to go back to the bathroom every 20 or 30 minutes in order to get all of the bowel movement out, right? So your life is kind of circling around the toilet again here. And then there's again the possibility of partial or full incontinence depending on what your sphincter control is, because remember, we had that whole fancy nervous system that is now replaced with a dumb colon, right? So again, we're going to sit down in the clinic with your mom and talk about what she cares about, right? Is she able to get to the bathroom every morning several times a day? And if so, maybe that's a good idea. If she's kind of like out and about, you know, she's like, I'm about to take a backpacking trip to Peru, maybe it might not be a good idea, right? We talk about assessment of how well they're going to be able to tolerate either of these types of surgeries. So patients with cancer are typically an older age group, right? And so they may not have the physical reserve that a younger person has. And actually, sometimes the psychosocial support network is very different in that group. And we finally talk about a multidisciplinary approach where we time surgery and radiation very precisely. And again, eliciting priorities is the first step of doing that. And that allows us to align what the choices are going to be with what the patient really cares about. And actually, interestingly, some studies have found is that marital status in the older age group frequently dictates what the choice is of colostomy versus low anastomosis. And patients who are in a strong supportive relationship with a partner will typically go for a colostomy, and patients who are single and have body image as an important factor in that decision will sometimes go for a low anastomosis, even knowing that they're going to be dealing with the bowel movement issues that they might be dealing with. And again, any surgery in this area can affect sexual function, and so that's actually a discussion that we have, frankly, with patients before the surgery. So go back to the clinical scenarios that we talked about in the beginning. So the first patient, you had ulcerative colitis, and you were choosing between an ileostomy and a pouch. So did anybody change their mind during this? All right. So for the people who changed their mind, who changed their mind from a pouch to an ileostomy? Okay. And then did anybody change their mind in the opposite direction? Okay. Who kept their choice of an endoleostomy? Okay. And then who kept their choice of a J-pouch? Okay, so it's a little bit more mixed now, right? Now that you understand kind of what the rest of the benefits are. All right, how about your other patient with rectal cancer? So did anybody change their minds? Who changed their minds at all? Anybody? Okay, so a bunch of you changed your minds. And who changed their minds from an ultra-low anastomosis to a permanent colostomy? Okay. Anybody change your mind in the opposite direction? No. And did anybody stick with this colostomy? Anybody? Okay. And anybody stick with the ultra-low anastomosis? All right, a couple of people, right? So things change, and kind of going through that and understanding more is an important component, and that is the crux of this and what makes colorectal surgery so cool. So really what the right choice is very, very dependent on who you are. And actually the evidence tells us that too. So I'm going to give you a couple examples. So this is representing me, right? So I would absolutely choose an endoleostomy if I had ulcerative colitis and I needed surgery. Why? Because I'm a surgeon. I stand in the operating room for 6 to 8 hours, sometimes even longer, and don't have time to kind of go to the bathroom several times during the day, right? That would kind of mess with my life. On the other hand, I actually had a patient who was a model, and the ability to still have a normal abdomen, even if there were scars on it, was very, very important to this patient. And so this patient chose a JCAP, and many people do, and many of them do really, really well with it. And what we found actually is that when we educate people appropriately, like we just did during this lecture, about what the choices are and how it aligns with their own life priorities, about 20% change their minds, and about 33% actually strengthen their certainty. And these are people who may have done a little bit of headway research before even meeting the surgeon. So we kind of saw that illustrated. Again, let's go to the rectal cancer too, right? So these represent a couple of other patients, right? So I had a patient who was a truck driver with rectal cancer, and he came in absolutely refusing a colostomy at first. And when we talked a little bit about what it actually means to have a low anastomosis versus a colostomy, he said, gosh, like my job, I love it. I drive long distances in my tractor trailer, and I'm not going to give that up, and I can't just like stop the truck every 30 minutes to go to the bathroom. So he ended up choosing to have an endocolostomy permanently, and he was incredibly happy with it. So the evidence also tells us it's a very personal choice. There's a really great New York Times article actually recently about what would you do if this were your mother? And the guy replied that the answer to that question really is, tell me more about your mother. Because what your mother's priorities are and goals in life are really what should dictate that choice. And what we find is that actually 1 year out from this surgery, regardless of what it is, if you choose the colostomy or you choose the connection, people actually overall, when you survey them, have an equivalent quality of life with either choice. And so what was once frightening and unimaginable to someone may be something that gives them the best quality of life possible. And then finally, when you look at cultural differences, this bears out again. So in Europe, where people have actually an even stronger cultural aversion to stomas than we do in the United States, a much, much more significant proportion of patients tend to go with a low anastomosis. And what they do is when they're unable to be continent of their bowels from below, they're wearing diapers. But that is a culturally more acceptable standard in Europe. And people actually end up with the same quality of life because of what's culturally acceptable there. All right, so I'm going to put on my education hat for a couple of slides to kind of go back to talking about how we think about these questions and answering them and prioritizing them actually can affect how you move through life as a learner. And in my case, I try to teach patients that so that they can kind of better cope with their disease. And in your case, it can actually help you learn and progress through failure. So mindset is actually an interesting field of study in psychology. And that first quiz that we just took was actually looking at the difference between a fixed and a growth mindset. So a fixed mindset is basically the idea that your intelligence is an innate characteristic about you that you can't change. And a growth mindset is the belief that your brain and your intelligence are basically just another muscle that can be flexed and improved. Now, I know that Dr. Andres told us that we were born with most of our neurons the other day, but the connections between the neurons are the things that can flex and change over time. And so you may not even know it, but people actually have typically one of these two mindsets. And it has some significant implications for how you're going to behave when you're faced with challenge and faced with failure. So research in elementary through high school age students in the education field shows that when students with a fixed mindset are faced with a challenge, they will tend to believe that they are not smart and give up because, well, you can't do anything about it, right? So I'm not smart enough to overcome this challenge. And so they will prefer to complete easier work because you know that you will succeed. And students with a growth mindset, and on the other hand, will kind of work and display a desire for challenge and show more resilience in the face of failure because failure is just another opportunity to learn and to grow your brain. And so think back to kind of how you think about intelligence, and if you can actually move yourself towards a growth mindset, it's going to be a really big benefit for you. Mindset is actually something that was most well studied by the psychologist Carol Dweck at Stanford, and you can see her quote here. And when they looked at American students in high school, they found that about 40% of us are fixed mindset, 40% are a growth mindset in high school, and about 20% are mixed. And so it's interesting to think which one are you and how can you move towards the beneficial one. Evidence also actually shows that your identity is a mindset. So there are some interesting studies of Asian female students taking math tests. So when the students were asked to identify their race before taking a math test, and they identified as what they thought might be smart Asian, they did better on the math test. And when the students were asked to identify their gender before taking the math test, female, not traditionally smart. Did I just say that out loud? They did more poorly on the math test. So keep this always in the back of your mind. I'm going to give you one last kind of tidbit with a personal illustration. So on the left is me circa NYSC 2001. And what I actually didn't know back then was I was a fixed mindset student. I didn't actually realize this until I went to grad school. I thought I was very smart. And then I went to college and I got 3 or 4 C's and went, oh, am I not smart enough? And it wasn't actually until many failures later that I learned that that is not the most important thing, and that you can actually overcome those to keep getting smarter. So I'm going to leave you with that illustration because sometimes I think seeing the failure is a good way to kind of reflect on that for yourself. All right, that's all I got for you.
Uh, 10 minutes for questions.
Why does coffee make you poop?
Why does coffee make you poop? So actually there's a recent study that was it was published with much fanfare and presented at the major digestive disease conference, that it's actually not caffeine in coffee that makes you go poo. So they actually fed mice different drinks that have caffeine in them and found that the mice who had coffee pooped and the ones who had tea, which still has caffeine in it, didn't go poo immediately. And so we think that it's some other compound in the coffee that's causing that. It's probably interacting with your enteric nervous system. Yeah.
As an option on YouTube, how common is ulcerative colitis? What elements?
Don't worry about it.
Okay.
Yeah. I think that it was studied in in certain families. So the question is, how common is it in Ashkenazi Jewish populations? And I think there are many diseases that were first studied in very tightly knit communities. And so we tend to associate them with those communities, but it doesn't mean that you're necessarily, nowadays we know that you're not necessarily at a much higher risk. There's probably a small genetic component, but we are now finding all sorts of different ethnicities that we didn't think could have ulcerative colitis or Crohn's disease who come in with those diseases. And so it's more than just that.
How common is it overall?
How common is ulcerative colitis
Yeah.
overall? So the number of new diagnoses in the U.S. is probably in like the tens of thousands.
When is ulcerative colitis usually set on?
When is it usually set on? So there's a known demographic distribution. So typically the first peak is in the 20s to 30s, and then there's another peak in the 50s to 60s. And we don't know exactly why.
And what was that?
Sorry, what?
Was that ulcerative colitis?
Ulcerative colitis, yeah. The question was, what is the demographics?
So how does your treatment for ulcerative colitis or rectal cancer differ from treatment for more minor kind of diagnoses like tears in the wall of the colon or diverticulitis?
Yeah, so the question is, how does the treatment for these two diseases differ from those of more minor diseases? So tears in the walls, basically, if there's an anatomic problem, then you have to fix it. Diverticulitis is actually a really interesting disease process in and of itself. So it has its own kind of progression, and we've, over time, by analyzing the data of all the people who come in with diverticulitis, found that actually surgery is not necessarily always the best answer for diverticulitis. And so it's another example of a disease process where we're constantly refining our treatment algorithm for patients, and that medical management is sometimes better. So, yep.
So, two quick questions. One, when you take out the entire rectum and colon, what happens to all that space?
Oh, that's a good. So the question is, what happens to the space when you remove the organs? Well, in your abdomen, the other organs go to fill it up. There's actually, when you actually end up looking at it, unless the colon is about as big as the one that we saw in that picture, the space is not that much. So everything moves to fill it. When the rectum comes out, your pelvis is actually a bony cup, right? So your abdomen can squish, but your pelvis can't. And so something has to go in there to fill that space. And so when we put a pouch in there, the J pouch is the thing that fills it. And if we choose not to, then sometimes the small valve will slip down into that space. Okay, we're in this. Yes.
When you have the circle and stapler picture, how do you get that out?
So what happens is the stapler goes in the bottom, and an anvil attaches from above. The two click, it staples, and then it actually fires a knife on the inside of the circle to divide it, and then you pull the whole thing out from the bottom.
So, I guess this might not sound great, but like, what are the real drawbacks? Like, when like the poop goes into the body, maybe like a bloodstream or something, like, what are the concerns following that? Is it like infection? Is it related to like toxic blood? Or like, what are the main concerns when like poop goes into like the body?
So the question is, what happens if we have a leak or a fistula and the poop comes out into the body outside of the valve? And you pointed out exactly what the concerns are. So the poop collects in an area where it's not supposed to be. It has bacteria in it. It finds a nice place to live, and then boom, you have an infection. And so that infection needs to be treated with antibiotics. It needs to be drained out. Or if we can't get that area to heal and seal with drains and just those two measures, then maybe we need to go back in and either fix it or remove that entire connection altogether.
Yeah. Are there things that you can do in your diet to prevent ulcerative colitis from happening?
That's a really great question. So everybody asks this question, and I think it goes back to the root of we don't really know to begin with what brings it on in a lot of people. So kind of the short answer is probably yes, but I don't know. The longer answer is that in some populations, so Crohn's disease, which is a related inflammatory bowel disease, we've actually found that in kids, when we feed them a very specific controlled diet, it actually improves their Crohn's disease. So we know there's something about the interaction between the internal environment inside your gut and the gut lining itself that actually it drives the inflammatory process or cools down the inflammatory process.
I'm curious about how long you stay with these patients. Obviously, you find a lot of them that have cancer, but then if it metastasizes to the liver, are you still the general surgeon that's staying with that patient through the process, or does it vary?
Yeah, so the question is how long a colorectal surgeon stays with these patients through the process of their disease. And the answer is we do stay with them throughout the entire course of disease. And that's actually one of the reasons that amongst the surgical subspecialties, colorectal surgery is a little bit more special. Because many surgeons operate and remove whatever is ailing the patient and then off they go into the wilderness. Colorectal patients will often see our Crohn's and ulcerative colitis patients many times through the course of their life, even as they might need another surgery. Rectal cancer patients come to me for an initial consultation. We talk about the cancer. They may go off to radiation treatment for, usually it takes about 8 weeks. They may actually have preoperative chemotherapy in addition to that, so that may take another 6 months. And so I may meet a patient and then see them back in 6 to 8 weeks, and then again in another half a year before it's time to do their surgery. And then after we do their surgery, I follow them for at least 5 years, checking to make sure that their cancer doesn't recur and potentially taking care of the recurrence if it does happen.
2 more questions.
Okay. Go back here.
Do you think there are any applications for regenerative medicine with
For colorectal surgery. So the question is, are there options for regenerative medicine? So I think that if we were really creative, maybe in the far, far future, potentially yes. One thing about the gut, so you're going to hear about liver transplants, kidney transplants, pancreas transplants, face transplants, like pretty much a lot of things are getting transplanted these days from one person to another. And you never hear about gut transplants, right? So there are a very, very select number of centers out there that do small bowel transplants, but nobody does large bowel transplants. And the reason we think is that the milieu is so dependent not only on you and your genetics, but also on the genetics of this bio that naturally coexists with you in a synergistic manner in your gut. And we haven't been able to figure that out. And actually that is one of the hottest topics of research in colorectal surgery and gastroenterology is what is going on, what is the actual genetic profile of the microbiome inside your gut, because that determines a lot. I think I have one more question. Sorry, I think you had first, so.
So are women able to get pregnant following a PayPal procedure or any of these, or are they more like IVF or other?
That's a great question. So the question is, are women able to get pregnant after a J-pouch or any of these other procedures? So we'll define the difference between fertility and fecundity first, and this is very exciting for science camp. So fertility is the ability to get pregnant through normal sexual intercourse. Okay, wrap your heads around that. And fecundity is the ability to get pregnant by any means at all, and that includes in vitro fertilization. So when you think about it from an anatomic standpoint, fertility depends on the ability of the eggs to travel from the ovary through this magical space into fimbria, the fallopian tubes, and down into the uterus, and then combine with the sperm there. And fecundity just means that you have to have an egg that can be removed and combined with sperm to create an embryo, and then it can go back into the uterus. So fecundity is helped by in vitro fertilization. So going back all the way to what these procedures are, when we irradiate the pelvis, when we do surgery in the pelvis and take something out and potentially put something else back in that same place, we do mess with that magical space that the eggs have to travel through, and sometimes people develop scar tissue. What we found is that people who have a J pouch and then try to get pregnant are successful on the first 2 tries, somewhere around 50 to 60% of the time. So it still can happen, and it's pretty good. And if they would like to get pregnant by in vitro fertilization, that bumps up to around 90%. So the short answer is yes.